All right, hello and welcome everyone. This is Caleb from TASC at the National Rural Health Resource Center. This is our sixth and final presentation for our Learning Collaborative 201 focused on the transition to value. Thank you for joining us. Today's presentation will focus on the big picture and results matter evaluation and the ability to demonstrate outcomes. But first we thought it would be good to take an opportunity to discuss people's action plans and the activities that they've at least drafted up in relation to the 5 presentations thus far. And we thought we would ask for brave volunteers to discuss at least 1 or 2 of the roughed out action items on your action plan. Do we have anyone willing to volunteer before I start picking names? Star 2 will unmute your line. Anybody willing to volunteer?
Hi, Caleb. It's Lynette from Pennsylvania. I think Jen's on the call with us. I'm working from home today. So I can tell you one for sure that Jen and I started working diligently on this action plan, and so I can share with you. And Jen, please intervene if you'd like. I'm going to discuss for one of the activities. I am going to review and synthesize literature related to care coordination in COPD with all of our critical access hospitals. And then the activity lead obviously would be me. Timeline will be ongoing, and the partner contract will be the Flex team, Jen and Lisa as well. And outputs will, hopefully we'll be able to provide webinars and email distributions with all the educational resources and everything, such as the COPD manual we're working on. We would like to get everything submitted to all the critical access hospitals within 2 weeks, and then distribute updates as needed on an ongoing basis. Our outcomes will be hopefully that all Pennsylvania CAUSE will participate in everything that we provide for them, and they will have a better understanding of care coordination in the COPD and how it relates to population health and hopefully maximizing optimal patient outcomes.
Awesome. I dig it. I like it.
Okay,
especially
good.
With all of the recent efforts related to COPD, care coordination, it's a great way to get started and start that conversation with some of those hospitals if they haven't had it, and continue it if they have.
Okay, great. And so that's one of them. Jen, are you on the line? She may be still with Lisa. I know they were having a meeting. And we have a few others that we put in here. We want to obtain feedback from CAW leadership to determine their knowledge base regarding the transition to value and population health. Before we can give them any additional resources in education, we have to understand what their knowledge base is. Once we have a firm understanding of what that knowledge base is, then we will present them with educational materials that are kind of individualized for each of the hospitals and what that knowledge is. So we're going to critique it. And that's, Jen and I will both be the lead on that. That will be ongoing. Our partners will be the Flex monitoring team, CMS, Lisa Davis, and we're planning on delivering quarterly educational seminars, webinars, and face-to-face meetings with our PA CAW leadership teams. And the outcomes that we would like to achieve are Pennsylvania CAUSE will have access to the necessary tools for implementing transition to value and population health initiatives, and Pennsylvania CAUSE will identify any challenge or barriers that may delay progress. So there's two. I don't want to give all our goodies away.
I did. No, that's great. I think that's really good, Lynette. Thank you, and thank you for volunteering. And I think that's a great example of objective, who the lead's going to be, timeline, partner organizations or contacts if you have them, or if it's just going to be something within your organization, the outputs, and comparing and contrasting that output compared to outcome. I think those are great examples and a good start to sharing. Who else would like to share at least one of their roughed out objectives for their action plan? Mr. Daniels, would you like to share? *2 will unmute your line. There you go.
Well, if I'd wanted to, I would have shared. But mostly, at this point, it's what the action plan is more along what Lynette shared, sort of on the second item, which is basically assess where everyone's at. The critical access at the hospitals here are at different stages. Some have started to enter ACOs, others are still sort of taking a wait and see. And so basically do an assessment of where everyone's at, what their needs are, and basically develop trainings and resources along that continuum to assure that that everyone has a smooth transitions into ACOs or other advanced payment models. That's primarily what I'm looking at the moment. So it's basically do an assessment and then develop the resources based from those assessments, and then begin monitoring once we have those in place. So.
Awesome, great. And a measurement of outcome success measurement will be how many CEOs you get to complete your assessment, or further down the road you're able to.
For initial, that'd be more process. I'm looking for outcomes further on down the road. Basically, once people have made their decisions, those that have decided to go into advanced payment models, basically seeing how that's working in terms of basically providing both better quality health outcomes overall, but also the big thing that I'm sort of looking at to see how it impacts their financials if they're able to make this into a financially viable model, if it puts them in a better financial situation or a more stable situation than they're currently in. And one of the things that I can monitor here is basically how much they need sort of the state subsidy. Most of the critical access hospitals get a state subsidy because most of them are not making money, but if they can reduce their dependence on that, then that'd be a sign of success in my book, or that'd be one of the measures that I'd be looking at from an outcomes perspective.
All right, I like that, and it makes sense. Again, it's Hawaii specific, it's unique to your guys, and taking that information and seeing what's beneficial and relevant to your hospitals as opposed to just how many of them are doing X. Noted.
Right.
All right, fine. I dig it. Who else would like to volunteer? I want to get a few of these, so those who are having a bit more either difficulty or not quite sure where they are in this, they get a better understanding of those who are further on down the road. So when we call for TA to help develop an action plan for those guys, they kind of understand how some of the Lynette, Scott's, and others are a little further ahead. Who else would like to volunteer? *2 will unmute your line. Thank you, Scott.
Hey, Caleb. It's Jen Edwards. I'm on the line. Sorry, Lynette. I was late. Lisa and I had another conference call. One of the things that I just wanted to mention was, and we are a little bit further along here in Pennsylvania because of the Pennsylvania Rural Health Model. So one of our critical access hospital meetings, our November 7th meeting coming up, we actually decided just recently that we were going to do a Rural Healthcare Transformation Summit, Volume to Value. And the morning is going to be involved with, it's just going to be one of our normal critical access hospital summits, but we're also going to be inviting SHIP and other small rural hospitals, as well as rural health clinic leadership, and we always do kind of a breakout with our quality improvement directors. So the morning will be an all participants section where we'll have 2 panels talking about the value of primary care and community-based preventative care. And then our second panel will be on population health innovation and really talking about behavioral health and substance use disorder, as well as care coordination, COPD. And then we are lucky to have Kelly Braun in our office that does oral health integration into primary care. So just some more innovative, moving from volume to value type initiatives. And then in the afternoon, we're going to have separate breakouts with the rural health clinic leadership. Our hospital leadership will be in a separate breakout, and then our quality improvement directors, and then we'll have more specific, discussions in those breakout sessions. So just as something else to think about, it's as easy as taking one of your critical access hospital meetings and maybe expanding a little bit and, bringing some speakers in that have done some innovative things in your state or that are moving more into population health-based, care. So just as something else.
Great. Thank you very much, Jen. I think that's a great point, that it doesn't have to be a huge diversion or something new to your work plan. It can be adding on to or supplementing, or really something that's already in your work plan. You're just now having this collaborative, now you have a better understanding of what you're talking about, and now we can have some more depth or richness to it. So thank you, Jen, for helping, I guess, talk through some of that. Yeah, we already had that meeting on the books before you guys were, joined up this collaborative. But, now we can think about that in a little different way, or add a speaker to that agenda and focus some of that conversation on the transition of value. I think that's a great idea.
This is Craig from Minnesota.
Great. Howdy, Craig.
Hi. We submitted our kind of action plan a little while ago, about a month ago. But what we're going to do is have a Flex Advisory Committee forum on value-based purchasing, population health, and global budgeting. And then we're going to look for output measure members present, ideas generated, and what supports need to be in place for CHs to explore value-based purchasing, population health, etc. And we're going to analyze, we're going to develop a survey and then put that out and see what kind of results we get from the survey to see where people's understanding are at with value-based purchasing and population health. And then we're going to use the advisory committee input to ID survey questions on outputs and outcomes. Then we're going to work on readiness, tool technical assistance responses generated from the survey. And then in the spring, we're looking at a spotlight on value-based purchasing and that's on information to improve survey results, depending upon timing. Could be two different events. But that's what our plan is in general here.
I think that makes sense. It's a you guys are doing a bunch of different things, assessing and working with different partners to identify survey questions to make sure you find and ask the relevant questions. I think that's important. I think that's good. Any questions for Craig or any of the others who shared some of their initial thoughts on their action plan items? *2 will unmute your line.
One question I have is, our state doesn't seem to be progressing that fast in these areas. There's some,
right,
but I looked at a Kaiser report, so I was just curious how other states they're progressing fast in this, or just kind of starting.
I think overall, and Shannon, please feel free to answer this question, as you're probably the best informed of all of us. I think there would be a standard bell curve distribution of all hospitals joining advanced payment models, but critical access hospitals as well. There's some that are all about it and in on it, and the Crystal and Jeff from Michigan, as well as our Illinois participants, they have and run ACOs out of their flex office, and their critical access hospitals are part of that. John in Vermont has a bunch of hospitals joining by hook or by crook the advanced payment models. So, and some they're getting encouragement, pressure, however you want to phrase it, to do so. And then there are some that have absolutely no connection at all within the same state. So, Shannon, what do you have to add on that, just the distribution of hospitals joining advanced payment model or value-based purchasing?
So I think that you have the entire full spectrum of those that really are still holding out, and those that have joined as advanced as possible, as we've seen. I would note that probably the two that I've seen are, of course, that Pennsylvania model, glad you guys are on, and then also the whole entire state ACO in Mississippi. That one's new and launching about on the same trajectory as the Pennsylvania model, and two different models completely still, focused on the end game. I think I don't have a sense of just cost, but from a provider perspective in the primary care, the rural health clinics connected to cause that are the smallest of the small are having the biggest problems. There are also a host of individual practices in rural communities that probably fall in that same category. And that really relates to the topic of tyranny of small numbers. In other words, having the need to be able to connect in order to become statistically viable and create enough volume to have significant evidence of the outcome. So, and that's part of what we talked about. So percentage-wise, I think it's still probably somewhere in the low end of the middle. I don't know that we have a massive amount of the people across the country that are in ACOs. Those are harder to get into and harder to participate in because there's not that many options other than Caravan. And we do have some advanced ones in the country that are doing their own. So they're out there, but it's kind of all over the board still.
Great, thank you. And I think I don't want to take up any more of your time, Shannon, for the presentation side of things, but those of you who are not able to share, please email or post a draft up on the external SharePoint page, as well as the final draft for your action plan should be posted to the external SharePoint by the end of the week. Please reach out to me and or Andy if you have any questions and would like, I can do like, half-hour phone call discussion for drafting up some action plan items to help walk you through that, especially if this is one of your first action plan drafting sessions. As we said, it doesn't have to be big and grand. It can correspond or dovetail nicely with your activities and your work plan currently. That now today is the first day of the new Flex Cooperative Agreement. So I'm sure all those activities have been started with great fanfare. We can just add on to those. So just let me know if you have any questions, and we'll help support those. But yeah, Shannon, anything else before we get started, anyone? All right, Shannon, I think that silence is your cue.
I think it is, and thank you, Caleb. And also thanks to all of you joining today, and especially those that have volunteered. This, of course, is the last of the 6-week Learning Collaborative 201. And I want to reiterate the intention of this whole Learning Collaborative and the angle that I used was really to look at the overlying vision of where you should be trying to get to. There's certain components that you all have to do. We didn't drill down specifically in one whole entire webinar, but I touched on those. I think those are readily available. A lot of information is already available through the people that are doing good work, either in the country or especially in all of the material that you see in the National Rural Health Resource Center. But I wanted you to understand some of the reasoning and the absolutes that we're seeing across the country. Hopefully this will help all of you. So again, thank you to the National Rural Health Resource Center and all that you guys do specifically in these 5 areas of transition to value and population health, collaboration and partnership, performance improvement, health information technology, and workforce. I think we've touched on a couple of those this last 6 weeks. And as Caleb said, this is the 6th and final of this webinar series. The first was really intended to focus on what's happening in Medicare, who's the leader of the country in transformation. The second in paradigm shift was really to raise it up beyond just Medicare and look at what is happening in the commercial space and how that ties into what's happening in Medicare. The third was looking at accountable care organizations, but not only those, and sort of the components of all that, and what's the value in rural participating in it that gets you to just accountable care organizations, but also commercial payments. The fourth was clinical integration network, and I think those are going to be almost impossible not to do the work that you need to do as we move along the spectrum of transformation without some sort of collaboration, coalition, or network. Finally, last week I really talked about a subject that is ruling all of the rural providers and engaging in this value-based work, and that is the tyranny of small number. So I'm going to try to turn all those together, connect them all together for you, and make it be somewhat significant for the total picture of what we're working at today. So the highlights of that first one was that Medicare is changing, and you know, if you had a few points to walk away with, the first is that Medicare is not yielding on this intention to bend the cost curve and to purchase high-quality care. What the result of that is that you must know that you are going to have to change not only in payment but in delivery. We talk a lot about transformation and payment reform, but that also includes delivery reform. And the two feed each other and actually create it more valuable if you're changing the way you deliver and to get the better payment. It makes me think of meaningful use, and people used to say, oh, it's just another hat I have to wear. We kind of have to reconfigure and decide if it's another hat or it's integrated into one in a new way. It really seeks to change the whole entire system. The other thing that's coming is that there is a pressure to engage in risk. And I think that's something that all of us in this collective and the body of work that we do really need to pay attention as to what Medicare is intending on risk. This is a very difficult thing in low volume. It's not necessarily wild successful even in large volume, but there could be great returns on investment if you're able to stabilize the engagement of risk. So this is on the horizon. It's not pressured right now, but they're closing the windows of when you can learn from Medicare in something like an ACO to engage in risk. And I'll touch on that hopefully in just a few seconds. The other thing is that the system is really leaning towards giving greater advantage in those that are taking on and trying to participate in risk, which has the result of significant disadvantage in engaging in it. And the further we go along the spectrum, the harder it's going to be to win in scores on MIP and to be able to engage in the participation in ACOs or other value-based programs. Number one is that as you move forward on this spectrum, the engagement of providers look for other people who are as far along in the spectrum as they are, because they have fought long and hard in order to create high scores to get better return. So the sooner the better. The sooner the better that you understand what engaging in value-based is, that you have a better chance of having choices of engagement in the future. And finally, we see right now that there's not necessarily a way to increase in reimbursement in Medicare unless you're engaging in pay-for-value programs. That might change. We'll see. And what HHSC decides to do, but listening to Seema Verma's offering in the May presentations that she did in Atlanta, she gave all of these. I won't go through all of them, but she did not yield in the models that are being offered. And in fact, you look at bullet number 5, the 2 new models that said they were focused for rural communities, which is primary care first, it still requires risk. It still requires that you are documenting and that you understand what your value story is. And so even though they are saying we are trying to pitch something to rural providers, they are not yielding on the idea of the very first principles of that we really have to know our value story, and we have to then documenting that so that other people can see what our value story is in their information. This is just a slide that demonstrates that. If you remember, we looked at those bubble charts on the XY graph that was early on in the Transforming Clinical Practice Initiative that showed us that not only Medicare, but commercial payers across the country, almost 3/4, almost 226.3 million lives across Medicare and commercial populations as well as Medicaid were in this study. And as you can see, moving to the right, left category 1, of course, as a reminder, is fee-for-service only, and categories 3 and 4 being full capitation risk, and 3 taking some, 2 and 3 actually on a platform of some fee-for-service. But what you're seeing over time, green being 2015, blue being 2016, and orange being 2017, is that they're reducing over time in categories 1 and they're moving in categories 2, 3, and 4. This is the offerings across the country in order to increase payments in negotiations. So, when I was in the field for the last 5 years, early on, the resistance was, I'm not going to make a change. I'm too small. There's no difference to be made. I can still hang on. And I think that is a pretty tough story today. And this demonstration is showing that it is pressing forward. There are easier ways to engage than not, and actually have the problem of being deemed a not valuable provider. So the other thing, besides commercial payers and Medicare, is that you have this change around us in the demographic of people actually using our services. Certainly the baby boomers are moving into retirement age, which is a heavy weight on Medicare because it's the largest cohort moving into the Medicare role. But counter to that, we're seeing a lot of young people that are coming into the insurance population that are demanding more access through technology. So you see this growing divide on top of the transformation changes. You're seeing this growing divide of demand from the consumer themselves. This really also affects the outcome of the engagement of what a rural provider needs to consider. So technology the ability to have some pliability on delivery, and be able to manage that larger population of the Medicare folks that are demanding a lot of time and resources because of disease state, countering that with the young folks that are entering in with a whole new demand of delivery in regard to technology and more access. So in result of those things that I just addressed to you, demographic changes, changes in commercial, and changes in Medicare on payment and delivery reform, those three things really have put us in a place that we would call the paradigm shift. And that actually is a definition, and that is a change that happens when a usual way of thinking or doing is replaced by a new and different way. We are very much in the middle of a paradigm shift, and I would say that we are in the middle of the discovery phase. We're not actually in the early. I think the early's been around for a while, but we're in the discovery phase. Again, you could see that on that bubble chart that I showed you before. We're not in the absolute beginnings where everybody's sitting on fee-for-service. We're certainly not in the end where there's a host of people only on capitation. But they are seeking, HHS and payers are seeking for ways to get the results that they want and still have high-quality providers. It's an opportunity. The paradigm shift gives us an opportunity to engage and say collectively, this is what works for us. Pennsylvania is a great example of coming together collectively, having a rural voice nationally to say this is what's working and this is not what's working. So I see the paradigm shift as an opportunity, but again, this is to me proof that we are in the middle of a change and there's no holding out until it goes away. I wanted to add to you, and I did this, looks like I've lost connections. Can you still hear me, Caleb?
Yeah, we can still hear you, Shannon.
Okay.
We can advance your slide for you if you need us to.
Okay, thank you. I'm on slide 10 at the moment, and I'll watch to see when the connection comes back again. But Great. Slide 10 is the components of an alternative payment model, and what's important to note is that these are variables, but these four things themselves, the categories, are not necessarily variable. You're going to look at new payments for services, different ways in which to get paid, and that is going to continuously erode the traditional fee-for-service payment. You're going to see a way in which they can measure your accountability towards the total patient spend. And this goes back to that conversation I just had a few minutes ago about how all providers are going to be very concerned about referring and partnering with other providers about what their cost is and ultimately what their quality is, because Medicare is measuring it patient-centric and Medicare is measuring it based on a metric of cost and quality. And so those pieces may be stronger or not as strong depending on what payment methodology or payment model that you select, but those components are still there. And so you need to be aware what you as a provider's impact is on the quality measure and the total spend measure. And then finally, patient eligibility is that as people are becoming being measured by cost and quality, having patients be your patient is critically important in order for you to be able to capture and say those are my patients, because they get moved to pools of where they are measured. Again, this is the attribution of the alternative payment model accountable care organizations. These four things are always going to be there. So if you want to go ahead and try and change that, Caleb, it looks like I lost my connection. It's reloading right now, so I can move to slide 11. I have that on my slide deck.
Roger that. We are on 11.
Okay. So I guess what I'm pressing at this point right now is to say to you that the future of healthcare requires change, and that is both in payment and delivery. We can't be static on the way we're delivering care, nor can we be static on expecting the way we're getting paid. And if you go on to slide 12, in payment reform in specific, it's that triple aim, eventually called quadruple aim, but the triple aim was better health, better care, lower cost.
That's what I just described to you in those components of the alternative payment model. These words on this slide 12 really come from Medicare's Quality Payment Program, and I believe that it will stand true for the majority of what we see in any value-based payments that are offering you in commercial payments. I bring this as attention because I think that it is critically important to pay attention of the whole spectrum for rural providers, leverage the opportunity of what you get of the QPP and Medicare, because they're providing you data and an opportunity to, quote unquote, dip your toe in the water with information without downside risk for a couple of more years and a couple of programs. This gives you the ability to learn what your story is and what you need to do to improve your value story. So the payment reform would lead the way to the other type of payment methodology. If you'd go to slide 13, Caleb.
Yep.
All right, and so this is actually the definition of alternative payment model, and I would say this might actually apply to commercial as well as the government type programs. In my words, an alternative payment model is an agreement to be measured on cost and quality of a defined population in order to receive a new type of payment. It's a measurement of cost and quality to get a new type of payment. That seems a little less complex. You get labels put on them and put them in boxes, ACOs, direct primary care, bundle payments, all different types of things. But if you consistently apply your work to knowing that you're going to be measured on cost and quality and you're going to get a new type of payment, you will be able to apply that definition to almost any type of payment methodology in the future. We also know, and moving to slide 14, that in delivery reform, and this is not meant to be taken lightly, and it's certainly the front edge of it, because I think as you move forward and become more advanced, it's a whole lot more than this. But from a small rural primary care perspective, the delivery reform is focused first on primary care, which is what rural foundation sits on. And there are three basic strategies within population health. The first is that you would need to redesign your workflow and process around a nurse-led program. The second is you would implement prevention and wellness. And we spent a lot of time with this, I believe, on week 3. And then this one's critical, proper documentation, coding, and reporting. Each one of those have not been I would call a habit of excellence in the requirement for documentation of rural health clinics, specifically in the all-inclusive rate. And so this is a new skill set, but it is critically important, again, in telling your value story in the future. And then slide 15, Caleb, thanks for doing this. It's not popping back up.
No worries.
All right, so clinical integration is actually an opportunity, and I think that it's really, really vital and important. In last week's presentation, actually in 2 presentations, I've talked about clinical integration. Maybe WebEx 4 was specifically about clinical integration. And I really use the definition here of clinical integration from a clinical perspective. But what I wanted to note is that it leans on the opportunity of coordination of care across the spectrum and actually outside of your own tax ID number. This moves to the definition of clinically integrated network. And as we take the idea of clinical integration, which is written in those quality payment program objectives, working from patient-centric, working in a care team-based care model, including the patient as part of the leader of the team-based care. Clinical integration is important and happens generally under a network larger than a single tax ID. So if you'll move to slide 16. I did last week a little focus because there wasn't all of you on the call last week, so I want to touch on this, and that is clinical integration is continuous across the alignment of the care coordination that we've been seeing today. And this, in and of itself, and a local level, much less at a greater level of statewide or region at least, really starts to pull together the idea of lowering costs, getting better health, and getting better care. So this is integral in the opportunity to be successful in the future. And if you'll go to slide 17. Slide 17 really wanted to make the designation that clinical integration networks in and of themselves are not payment models, but they are a vehicle to provide access to the payment models. It's also a vehicle to create the legal environment in which that you can work across the continuum of care without being under the same tax ID number legally. So even though it's not a payment model, it certainly is the proper vehicle to be able to initiate payment models that give legal protections and great opportunities in reaching the goals of better health, better care, and lower costs. Okay, slide 18. I thought about, you know, from a high level of the last 5 webinars. And I think the 2 big problems that aren't necessarily always discussed when we talk about transformation, but I think these are the biggest takeaways that we have, especially from the flex side. When you have the ability to look at a state level, is the encouragement of addressing the problem of low volume collectively in groups, and then creating a collective value story. And there's 2 reasons in this. And I'll talk about that under the tyranny of small numbers. But the truth is that in order for us to have a voice about rural health, in order to demonstrate the cause and effect and solution of the chaos that we're seeing under the paradigm shift, is that we must all be, at a rural perspective, telling the same problem and telling, hopefully, some collective answers. An example of this was in '97 when I was working in Texas in a network of rural hospitals. Medicaid was going to start renegotiating their fee schedules, and they put out a really great book. They published it in paper, and now it's online, but at the time in '97 it was published on paper. It was called the Texas Medicaid Handbook, and you could actually see percentages of what the impact of any cohort or specific hospital was on the Texas Medicaid budget. All the rural in the state of Texas in 1997 represented 4% of Medicaid. One hospital in the Valley, which is our deepest population of Medicaid outside of the metros, represented on its own and by itself 5%. And in a time when you're negotiating and Texas Medicaid was drowning, they were taking over the whole Medicaid budget, Texas budget, you needed to have one story to be somewhat significantly important for them to be able to respond, them being the state of Texas. So if we look at that same analogy in the United States and say that rural health is around 20% of the country, and the country, HHSC and large payers, the BUCAs, what I would call Blue Cross United, Cigna, Aetna, Humana, and others, are all focusing on the 80%, not the 20% in population. We're experiencing unintended consequences, and for us to be able to be valuable, we really need to be able to tell a consistent story, at least at a state level, because the commercial insurance lines stay within state lines, and therefore to have a conversation with the state insurance company for what's happening in Illinois or Texas or wherever else. You really need to all have the same story about what works and what doesn't. So from a flex perspective in the state office, I think that's critically important. So that gets us to a point of low volume in the value story. If you'd go to slide 19, Caleb. To reverse that, that was looking outward, but to look inward in small volumes in the value story, rural providers, both their delivery system and their payment models are defined by limited and relatively small patients they serve. We have cause designation because of the small number of patients we serve. We have rural health clinics, all-inclusive rates because of the small volume of patients we serve. We are ruled by the tyranny of small numbers, and that rule puts us at a disadvantage when we are looking at statistics. And you can be assured in this time of chaos, when there's redesign of payment and redesign of delivery, that people are looking at statistics for analysis to be able to look at what the obvious is. There are always unintended consequences, and rural providers are, in fact, an outlier defined under the unintended consequences. So if you'll go to the next slide, please. Slide 20 now. If we look at statistics, and statistics create us as an unintended consequence, then the data they're using are ultimately excluding outliers. A lot of times the statistical rule is 1.5 or 2 points off of the average mean. And then they make a decision of whether or not that specific outlier is bringing something valuable or just skewing the data. When they make the decision that it's unimportant, they toss it out and let the data speak without that information in there. That's the way statistics work, and so it's really important that we become statistically viable. You'll go to slide 21. Slide 21 is that summary of what I just said. Managing the medical budget for a payer requires risk and risk analysis. Risk analysis requires statistics. In statistics, there are outliers. Because of the tyranny of small numbers, rural providers are outliers. If outliers bring or capture inaccurate information or carry little weight, they are considered unimportant. And if they are carrying a lot of weight or they give important information, we become really important. I think that it is critically important that we make sure that our story is consistent and correct in the story of our data, and that it demonstrates from a voice at each state that we are statistically important and that we do not need to be an outlier. We may be an exception, but I think that rather being an exception, we should be exceptional. And that requires that we tell our story. You guys have heard this next slide. Well, I skipped a couple of slides. Sorry, I got excited about the value story. Let's move to slide 22. So what is the rural option? We've talked about some complications, a lot of changes. We've talked about what's happening in the world today, and we've also talked about the barriers that are out there. We've asked this question every week, what is the rural option? I think that it requires a new way of thinking. If you'll go to slide 23. And this, I think, is the option for each of you as flex coordinators, is to coach your folks, your rural providers, your leaders in cause and rural health clinics. Ask them what they are thinking. Ask them if they can think differently. And maybe you can say, rather than we provide a service, we get paid, you can actually say, has that changed? How has it changed? And help them understand that. Help them know a different way to get paid. That yes, we may be an exception, but we are not too small in the collective, and we don't have to be exempt. We just need acknowledgement of the different type of volume that we bring to the table. We have to show our value, and we have to become statistically important. So next slide. going back to those statistics, that's the number two thing is number one, a new way of thinking. Number two has become very statistically important. There's no reason when there's 20% of the population of the country that we serve that 20% couldn't be a block of data consistent across the country to give a voice about change at HHSC. Frankly, I think they would appreciate that. I think it's very difficult to, with a lot of variation that we all seem somewhat different, there are platforms that bring us all together to be significantly the same. And in doing so, you give the ability of a power of a voice in the collective. And you do that through integration. So if you'll go to the next slide. And that's the opportunity in coalitions, collaborations, and networks. Those of you from Michigan and Illinois and even Mississippi if you're there, and certainly from Pennsylvania, and if I'm missing others, but you are already working in coalitions, collaborations, and networks. I think Indiana has a strong one too that I know of. But you gain the value of volume with patients and data and empirical evidence when you're in one of those three, more likely collaborations and networks. You gain infrastructure so that you don't have to go it alone in services, in governance, and in shared costs. You actually have legal vehicles to do things outside of the rural groupings, but still gives you the ability to maintain your value story, your perspective. It also gives that legal platform to do integration both clinically and virtually. And finally, it gives you the ability to have an option of not being aggregated into a larger system that's not rural and rural focused. So you have the opportunity to act as an enterprise but maintain your financial autonomy. And moving to the last most important thing that I would say, first is a new way of thinking. Second is becoming statistically important through collaboration. And finally, the last one is tell your story. And tell your story in data that's important to others, not just yourself. It's a concern to me when I Google that I don't find the value of rural health as something exceptional. If you're just searching out there, you find the story of hospitals closing, you find the story of rurals being the largest employer in the community, but I think we have the opportunity working in the collective and being able to, in whatever payer model you select, in demonstrating what your value is through proper documentation and coding and knowing what your volume is through that so that you can speak the language of others who are buying your services. You need to demonstrate your value story. And if there's one thing that you walk away from, I think it has to be this. So with that, I'm done with the PowerPoint. And Caleb, if you'll guide me if there's anyone actually typing stuff into the chat box.
Yeah, absolutely. Yeah, thank you, Shannon. I think that last point is really good to hammer home that there's some time to decide what you're going to do and where you're going to do it, but at the end of the day, especially for the critical access hospitals who are not necessarily in the forefront of CMS or any other payer's minds when they're structuring these new payment models, the opportunity is still there to do your due diligence on your end from the hospital point of view, telling your story, getting your processes in place, getting care coordination in place, working with the payers that are there currently, and making sure that you are in a position to tell your story and to share your value story. We heard for many years before these models came to be that critical access hospitals didn't provide more expensive care, that it does actually pan out to be cheaper, less expensive, with better outcomes from CMS. The swing bed program is a great example of that. But if you don't have the data to demonstrate that and the processes in place to do that for every one of your patients, especially when the volume's low, then it's not going to demonstrate in the data, and it's not going to be able to be told that your story. So I really appreciate that last bit there. What questions do we have for Shannon? *2 will unmute your line, or feel free to type them into the chat box. Andy and I can see the chat box still, and we can share them with the group or with Shannon. Questions? As we think of questions from the group for Shannon, and we got a couple people typing in the chat box, please take a moment to complete the polling questions. We had these at the outset of our learning collaborative, and now that this is the last webinar presentation, we want to find out where you guys are polling now. So thank you for taking a moment and completing the polling questions so we can ensure that our learning collaborative as well as other TA efforts or educational efforts are beneficial and relevant. We have one comment in the chat box that says, Shannon, thank you for sharing your expertise with us. I will second that. Thanks, Jen. Any other questions? Anyone else want to share their action plan items? *2 will unmute your line. In the meantime, thank you for taking a moment to complete the polling questions. We will get this recording as well as all other recordings and resources posted to the external SharePoint just as soon as possible for everyone, especially those who are not able to attend live. We will also dig around and see what resources we have that we can share. I believe we have a template or a survey or assessment that has been used previously for flex coordinators to send out and share with their hospitals to gauge their level of participation in advanced payment models or value-based payment models. So if that's the case, I'm pretty sure it is, that we'll be sure to save that to the external SharePoint page and send that out to you guys so you don't have to create another wheel if we've got one that just needs dusting off.
Thank you again for the comment. Yes, thank you everyone for participating.
Thank you. Thank you, Shannon, for helping us and leading our collaborative again. We have one more chat comment coming in. Thank you very much. Your knowledge is valued. Thank you, Kyle. That was great. Anything else, please email myself, Andy, or Shannon. We'll get back to you just as soon as possible. Otherwise, thank you for taking the time to complete the polling question, and we'll be looking for action